Cardiomyopathies mean heart muscle diseases. Now, we've been studying heart muscle diseases for a while now, and all of those were secondary cardiomyopathies. That means that heart muscle dysfunction was there, but that was due to a cause that was secondary to other problems. For example, due to ischemic heart disease, due to valvular heart disease, due to hypertension, etc. Now, when all these problems cause the heart muscle to get damaged in any way, that is called secondary cardiomyopathy. But when primarily the defect lies within the heart muscle, that is called primary cardiomyopathy. So there are three main patterns in which cardiomyopathies occur. First of all, we have dilated cardiomyopathy, restrictive cardiomyopathy, and hypertrophic cardiomyopathy. First, we'll see dilated cardiomyopathy. In this case, all four chambers of the heart are going to become dilated. This is a sort of hypertrophy, but in this case, sarcomeres are added in series and not in parallel, so the wall thickness may decrease or remain the same, but it will not increase. Dilated cardiomyopathy will stop the heart from contracting properly and properly pumping blood into the systemic circulation and the pulmonary circulation. So in this case, we're going to have a biventricular heart failure. But since this occurs during systole, that's why we call it systolic biventricular heart failure. Now, another complication that will arise is mitral and tricuspid regurgitation. Now, why is that? Because once we have valve dilation, these the two flaps of the wall will not be able to approximate properly, and they will not be able to close properly, and when there is a contraction of the ventricle, they will cause blood to regurgitate back into the atria. In this case, apart from the normal S1 and S2 heart sounds, S3 heart sound will also be heard. So we know that due to mitral and tricuspid regurgitation, we have increased blood in the atria, right? So as soon as there is ventricular dilation during diastole, blood will gush into the ventricles and get hit with the ventricular wall, and that is what will cause the S3 sound production. Dilated cardiomyopathy will also cause arrhythmias because the conduction system cells within the cardiac wall will also be stretched, and when they're stretched, they will become irritable and thus prone to arrhythmias. And as I said before, the atria will be congested and there can be stasis of blood, which will increase the chances of formation of mural thrombi. Regarding the etiologies of dilated cardiomyopathies, 20 to 50% of them are genetic. For example, Duchenne and Becker muscular dystrophies, these are muscular dystrophies in which what happens is that over time the muscle will be progressively weakened and dystrophic. Secondly, there can be abnormal oxidative phosphorylation because the enzymes that are responsible for this process will be defective. Secondly, alcohol has both a direct cardiotoxic effect, and also its metabolites also have direct cardiotoxic effect, and that can also be a reason for the disease. Thirdly, we can have toxins and drugs such as chemotherapy drugs, for example doxorubicin, etc., and cocaine are strongly linked with it. Fourthly, peripartum cardiomyopathy. So in this case, what happens is that in the third trimester or in the few months after delivery, what happens is that due to pregnancy-related hypertension and volume overload and even nutritional deficiencies, what happens is that we have a cardiomyopathy. This usually resolves but can be a problem in some cases. We can also have iron overload, for example in primary or secondary hemochromatosis, and that is because it interferes with metal dependent enzyme systems and production of reactive oxygen species, and this is how it will damage the myocardium. And lastly, we can have supraphysiological stress, that is if we have persistent tachycardia due to hyperthyroidism or any other reason that can pose unnecessary stress on the myocardium and cause it to dilate. Grossly, the heart is going to be flabby and there will be cardiomegaly, of course, and wall thickness may vary compared to hypertrophy, as I said before. The second type of cardiomyopathy is restrictive cardiomyopathy. So in this case, the heart muscle will be restricted. How? Because what happens is normally we have situations such as fibrosis, endomyocarditis, which will in turn cause fibrosis, fibroelastosis, etc. All of these things will cause the heart muscle to become more less compliant, actually less compliant, and then it will not stretch properly. So when it does not stretch properly, it will not fill during diastole, and then if we have less blood to start with, then of course the cardiac output or the stroke volume will be decreased. So since the diastolic function is impaired, that's why we call it diastolic heart failure. That is, the heart failure that will result from restrictive cardiomyopathy will be diastolic heart failure. In this case, the ventricular size is normal because there is only deposition of fibrosis in the ventricle, but the atria might dilate. That is because when the ventricles are not dilating and accommodating that amount of blood, then the atria have to compensate for that, and they might dilate if they are not undergoing fibrosis as well, that is. So regarding the etiology of restrictive cardiomyopathies, we have endomyocardial fibrosis. Now this disease is mainly of African children and young adults. It is the cause is unknown. There is dense ventricular subendocardial fibrosis. Okay, so due to that, we're going to have restrictive cardiomyopathy, of course, because there is fibrosis, and that will restrict the heart from dilating. Okay. Next, we have Loeffler syndrome, and in this case, we have Loeffler's endomyocarditis. So it is actually similar to endomyocardial fibrosis morphologically. But what happens is that in this case we have peripheral eosinophilia, and eosinophils are going to go and infiltrate the heart. We know that eosinophils has many toxic products which when released will cause damage to the heart, inflammation, and all that sequelae. And lastly, we have endocardial fibroelastosis. Now this is an uncommon disorder and its etiology is not known, but it is characterized by fibroelastic thickening of the ventricle. Mostly it occurs in left ventricle than the right. So this will have fibroelastic deposition and thickening, and thus this is also a type of restrictive cardiomyopathy. And lastly, we have hypertrophic cardiomyopathy. This is a common genetic disease of the heart which is characterized by heavy, muscular, hypercontractile and poorly compliant heart, and often it is associated with ventricular outflow obstruction as well, that is aortic or pulmonary stenosis, valve stenosis. So the clinical features will include decreased cardiac output, ventricular arrhythmias which can cause sudden death, and especially in athletes, hypertrophic cardiomyopathy is the most common cause of sudden death. We can also have subaortic hypertrophy of the ventricular septum, that is just below the aortic valve. The septum is going to be hypertrophied, and it is going to cause functional aortic stenosis. That is, the valve will be okay, but because just below the valve we have hypertrophy, it will be more difficult for the blood to go through this valve, and this problem will present as syncope with exercise when the heart has to work more. So regarding the pathogenesis or the etiology, hypertrophic cardiomyopathy is caused by mutations of sarcomeric proteins, especially beta-myosin heavy chain. So what happens is that the pathologic sequence is not clearly understood, but it is usually associated with these mutations, and as we know that it is a problem of the cardiac muscle. So there are some mutations in these proteins that will cause those problems. Regarding the morphology, we're going to have asymmetrical septal hypertrophy. So the ventricular septum is going to get hypertrophied, and it will be asymmetrical. That is, for example, if it is more protruded towards this side, then the ventricular cavity is going to have a banana-like shape. So this is pressed into a banana shape. So that's all about hypertrophic cardiomyopathy.